I'm thrilled today to have Tom Smith here, one of our Ellen Stovall Award winners, to talk about some of what he's learned in his career, what he thinks we need to do, and his experience as both a cancer doctor and now a cancer patient. So thank you for joining us, Tom, and congratulations on your award. We're so honored to be able to give this award to you in Ellen's name, and I know she would be thrilled as well.
Well, thank you. I've known Ellen for a long time through the American Society of Clinical Oncology, and I think it's quite an honor to be recognized in her name.
So what would you say are some of the most important advances that we've made in terms of palliative care and survivorship care during your career?
Probably the most important advance is to get palliative care involved early and often. When people think of palliative care, they think of hospice.
Right.
And dying. But many randomized trials now show that people who get the regular oncology care plus palliative care have half the rate of anxiety, half the rate of depression, better symptom control, less caregiver distress, and may even live months longer by having relief of their symptoms. Mm-hmm. That said, people still confuse palliative care with hospice care.
That's right.
I can tell you that our palliative care team at Johns Hopkins sees everybody who gets a heart transplant, and we see everybody who gets an artificial heart. So it's really not just about end-of-life care. It's about making the most of every hour, day, week, month, years you have. And there's a way to do palliative care that you really have to do it like it was done on the clinical trials. So I tell my cancer patients, I've got another team that I'd like to have see you along with me, and their job is to help fix symptoms by, first of all, asking you questions about all sorts of symptoms, fixing them, helping you adjust to this disease that you didn't ask for, help you turn your world back right side up when it's been turned over and around a couple of times. They're really good at pain management, they're really good at depression management. So it's an extra set of eyes and ears, and it has a physician and an advanced practice nurse and a social worker and a chaplain and a world-class pharmacist. I mean, who wouldn't want that team helping to take care of you? I know I would want that team helping to take care of me if and when I need treatment again.
So how do we make sure that all patients get this? Because, I was talking to a survivor recently who's in her 7th year as a metastatic breast cancer survivor, and she was just recently referred to palliative care for the first time, and she should have had that all along. And it's not because she's now finally experiencing some symptoms where she really needs that relief. She could have used that earlier. And she's seen at a major academic medical center, but then we also have patients who are seen in community settings where they don't have palliative care or they don't have access to the kinds of support that a Johns Hopkins might have. So how do we make sure patients get it?
I think the first thing is, like they say on TV, ask for it by name.
Right.
Ask for palliative care. Ask for a palliative care consultation. Because sometimes oncologists, like me, do what we know how to do, and we're sort of stuck in our ways. And it does mean I would have to call up the palliative care team and ask for a consultation. It doesn't mean that I'm admitting I'm a failure fixing somebody's pain, but it sometimes feels like that. But most centers now, even smaller ones, have a palliative care team available. It's up to 75% of any hospital over 250 beds, and the majority of smaller hospitals as well. In some places, hospice can fill in for that. And smart healthcare systems have recognized that it makes sense to have hospice and palliative care professionals take care of you along with your other serious illnesses. Mm-hmm. Kaiser Permanente did 2 studies now 15 years ago, and the group that got palliative care in addition to their heart failure care and their lung failure care and their liver failure care or their cancer did a whole lot better. Mm-hmm. The VA now recognizes you can have 2 years of hospice and palliative care alongside your regular cancer care. So the world is changing slowly. There is one website run by the Center to Advance Palliative Care called getpalliativecare.org. And that's the place I would tell people to look for the services available in their neighborhood.
So what about, you mentioned the fact that people still equate palliative care with hospice care. And I know we have to try to dispel that myth, but some people say the best way to dispel that is to call it something different and not use the word palliative care. And others are adamant that palliative care is what it is, and we just have to educate people that it's not just hospice. Where do you fall on that, or what do you think?
I've been on both sides of that argument, and I'm still firmly in the middle. Yes, if you call it something else, like call it supportive oncology, referrals from some physicians will go up, and referrals from some patients will go up. Some patients are still afraid of palliative care, equating it with hospice, but going to the supportive oncology clinic sounds like something really good.
Right.
So I would have no trouble rebranding ourselves as supportive oncology, supportive cardiologies. The flip side of that is we fought very hard for it to be recognized as a medical specialty. And somebody's afraid to go see the cardiologist, you wouldn't want to tell them you're going to see the person who takes care of that big organ in your heart.
Right.
So we fought very hard to have it be a specialty. I think the way to do it is to continue to show the message that palliative care helps people live longer and live better.
Right.
I mean, Ethan Bosch has done 2 trials where the big advance in their care was giving them an iPhone, and half the group didn't, half the group did. They got their usual care at Sloan Kettering. And once a week, they would swipe their symptoms, swipe left, right, swipe right, or swipe left for shortness of breath or nausea or pain. And in that group, there was somebody who would notice that, pick up the phone and call them and say, tell me what's going on, and either fix it on the phone or have them come in to be assessed. And there was an absolute difference in survival of 6 months out of...
Which wasn't even what they were testing for, but it was just the side effect of, the positive side effect of what they were doing,
It's
right?
a positive side effect. We showed that back in 2002 when we tested best medical pain management versus best medical pain management plus putting a pump with a little catheter into the spinal fluid to give medicines that can only be given in the spinal fluid. And they got 62% had significant pain relief compared to about 40% with regular medical management. And the absolute difference in survival at 6 months was 15 people out of 100. So if you get your pain relieved, if you get your symptoms relieved, however it's done, chances are you're going to live not only better, but longer.
That's amazing. So you've told me about some of the other kind of pain management studies and new techniques for pain management. Can you talk a little bit about how we're advancing in managing pain for cancer survivors?
Yes, there are some advances for cancer pain management. The one thing I would tell people that you should know about chemo-induced neuropathy is don't use the first medicine as gabapentin. There's a better medicine called duloxetine, trade name is Cymbalta, now generic, and it's the only drug proven to work against chemotherapy-induced neuropathy, whether it's painful, numbness, or tingling. And that's become the bane of my existence as a breast cancer doctor and the bane of my patients because it just interferes with everything you do, walking, touching, feeling things. We're having really good success with something called scrambler therapy, which feeds in electrical impulses on an 8 to 10-inch area of skin and sends them up to the brain and actually replaces the pain information with non-pain information.
Wow.
And you feel like you're being bitten by electrical ants, but sometimes, almost too good to be true, the patient's pain will just disappear. Or somebody will say, I can touch myself up here where I had my mastectomy. I haven't been able to do that for 3 years. How long is this going to last? And the answer is it lasts a fair amount of time. My longest has been 7 years so far.
Wow.
We're also having good success with my colleague Chao Xing Ye, who's doing auricular point acupressure, putting pressure on spots in the ears. So we've done this for outpatients, and she's recently done a study with oncology nurses in the post-operative setting. So somebody comes out of the operating room, they can still get their Dilaudid drip if they need it, but the nurses are also taught to do auricular point acupressure and teach the family how to do it. And she's seen a pretty remarkable drop in not only pain scores, but patients' fatigue scores, and cut their use of opiates almost in half.
Wow.
So that's pretty amazing
incredible.
for just something as simple and patient-centered as this.
Yeah. And fatigue is one of those things that we hear from cancer survivors all the time. It's just such a huge concern, and they don't feel like, in our 2020 State of Cancer Survivorship survey that we did this year, it was one of the top concerns where they did not feel like they were getting help with it from their healthcare team. And,
Right.
and I've heard some physicians say, well, there's not that much we can do. But I think, if there are things that can provide some relief for that, because it's really debilitating for a lot of people.
Fatigue is terrible, and I had it terribly myself during radiation therapy and chemotherapy. It's finally gotten a little bit better after 2 years. And there isn't an easy, simple fix for it, but there are some tricks of the trade, if you will, known to hospice and palliative medicine people. The biggest one is exercise. That study after study after study has shown that people who walk for exercise before cancer treatment do better afterwards and have a little bit less neuropathy. And if you walk during your chemotherapy and other treatments, you have a little bit less neuropathy and you recover better. And people who didn't walk before but then start walking up 20 to 45 minutes a day and maybe using some TheraBands to do some hip and leg exercises to maintain their stability, have a little bit less fatigue. So that's one thing that everybody can do. There are 2 studies done by the Mayo Clinic group showing American ginseng at 2 grams a day compared to placebo helps physical fatigue. It's not by any means a home run, but it's at least a bunt single, and it's probably simple and easy to do. I end up trialing my patients on it for a month. If you can do that for $20, and if it works, great. If it doesn't work, they really haven't lost anything. There are other pharmacologic manipulations you can do for fatigue. Stimulants like amphetamines, methylphenidate, which is Ritalin by trade name, modafinil, and a couple of others, work in a small percentage of people. I ask patients to rate their fatigue on a scale of 0 to 10, where 0 is no fatigue at all and 10 is the worst possible fatigue. The only people who benefit are people at this end of the scale,
Right.
who really have 8, 9, or 10 scores. And you can trial methylphenidate by giving 5 milligrams in the morning at 7 o'clock and 5 milligrams at 11 o'clock. You'll know if it's going to work with 85% accuracy within the first 2 days.
Yes.
And there's no harm done by testing that. I think the big thing is for physicians and advanced practice nurses not to just throw up their hands and say, well, there's nothing we can do.
Right.
The other thing that really helps is mindfulness. Mindfulness, meditation, and yoga all have significant effects on the improvement of fatigue. And most of them also have significant effects on cognition. Chemo brain, chemo fog, those changes we can see in the brain.
Right.
Yoga and mindfulness seem to really restore the balance in the brain and restore the brain waves to more closer to normal, and fatigue goes down.
That's amazing. I'm a passionate yogi, so I love to hear that. That's great. I do it every day. And it's made a huge difference for me, especially this year, living through COVID. I've committed to at least 10 minutes a day, and it's made a huge difference for me. Obviously, I don't have those, the side effects of cancer treatment, but it still helped me tremendously. So, okay, now I'm going to ask you a big picture question. So if you had a magic wand and you could wave your magic wand to make one big change in the cancer care system or lack thereof, and to make the biggest impact for cancer patients and survivors, what would you do?
It's pretty simple. I would ask healthcare professionals, doctors, nurses, advanced practice nurses, to look the patient in the eye and say, how are you coping with what's happened to you. And then listen. And you'll hear, this has really been terrible. We're in such deep financial trouble now that we never anticipated, and it's put a big stress on our family. It's really disrupted everything. So you know those things, and there's a chance you can fix some of them by getting help from a social worker or a chaplain. And then you physically turn to the family and say, your world's been turned upside down with Dad being so sick in the past year. How are you coping with him being so sick? And people will tell you. Mm-hmm. And it's such a simple, easy thing to do. In Jennifer Temmel's trial that she did at Mass General with 157 lung cancer patients, where half of them got the usual lung cancer care, which is superb at Mass General, and the other care met with the palliative care nurse or doctor once a month. On the first visit, they spent 20 minutes talking about symptoms and helping to fix them. They spent 15 minutes on coping with the illness. So asking the question, how are you coping, would be the very first thing that I would ask. Asking, how are you coping, is the simplest, easiest thing I can ask. We actually have it on a temporary tattoo that goes on your arm here.
Oh, that's awesome.
So I can sit here and say, how do you like to get medical information? Are you the sort of person who wants all the details or something else? And number two is, what's your understanding of your situation? Mm-hmm. And you can go on from there. That question works well at home too. Honey, what's your understanding of the checkbook situation? But you're never gonna know unless you ask. And doctors are afraid to ask because they'll think, I'll take away his or her hope, I'll upset them too much. I can tell you, as a person with metastatic cancer, there's nothing you can ask me that I haven't lain awake at night thinking about already. Mm-hmm. So let's just get it out in the open and talk about things.
And talk a little bit more about when you say take away hope, because I do hear people say that they're worried about taking away hope, but how do you think about that?
Doctors are afraid of taking away hope. First of all, it's not my responsibility to give somebody hope, so I can't take it away anyway. We've actually studied this, where we gave 27 people really honest, good prognostic information, and most of the time it was really bad. We measured their hope beforehand and measured their hope afterwards. What do you think happened to their hope after they were told, well, the average person in your situation lives maybe 4 to 8 weeks? Their hope went up.
Really?
I mean, it's that honesty that engenders hope more than anything else.
And what they're hoping for changes. Maybe they're not hoping for a cure, but they can hope for the
I hope that your
time
family
with their
comes back together again.
Yeah.
I hope that you and your wife, or you and your spouse, or you and your daughter can make up again. I hope that we can write down all the things that have happened to you so that your grandkids can read about them. I was interviewing an 80-year-old African-American woman just a few days ago. Imagine all the things she's seen change in her life, coming from the South, moving up here. And it's while you're still well, and I hope you continue to be well, it would be a great idea to write down or DVD or record parts of your life, what you want to say to your grandkids, their grandkids, when they ask about who this person was, who lived through very tumultuous times in the world and great changes for people in general. And usually when I say that, the family will chime in and say, see, I've been telling you to do this for 5 years and you haven't.
So you talked about living with metastatic cancer yourself, and
Yes.
I think you've been very open in talking about this, and I've heard you speak about it at our symposium this summer and in other settings. And your honesty about the challenges that you face, I think, is really important and helpful for I think other oncologists to see, one of their own going through this and talking so openly about it. How has it changed? How's what you've learned through your own experience changed how you take care of your patients?
Well, I wish I had some great answer for acceptance. I keep asking my own patients, your life has really been turned upside down, and now it's going to be pretty short. How have you come to acceptance of that? And people will tell you, well, I found faith in God, I found faith in my religion, I've really re-emphasized the importance of being with my family, I wrote all the things down that I wanted them to remember me by. Others never come to that acceptance. I've been very honest that I have prostate cancer that will probably at some point take my life, hopefully not soon. I've been also very honest about depression, because I had depression when I was a second-year medical resident and then didn't have it for 40 years almost. But when my testosterone hit 0 as treatment for my prostate cancer, my depression came back the worst it had ever been. And I actually had a tree picked out where I was going to hang myself. That's real depression. So I admitted myself to my own hospital for a week just for safety's sake.
Yeah.
Luckily, it all went away when I came off the medicine I was on and switched to a different medicine. And I don't feel like that at all, even 24 hours after I was admitted. But 15 or 20% of people are going to show significant depressive symptoms during the course of their illness. And it rarely gets recognized. And it doesn't have to be rocket science to recognize it. You can ask, are you depressed? Or have you been depressed most of the time in the last 2 weeks? And people will tell you. They'll say, oh, yeah. Or they'll say, I don't know. You know, life isn't as good as it was, but I'm getting by. We also see a tremendous amount of what our chaplains have termed demoralization, which is not depression. It's helplessness and hopelessness and being sick and tired of being sick and tired. They can whip out their iPhone and show you pictures of grandkids. They perk right up, but at the same time, they're sort of lost interest in things. It's that learned helplessness and hopelessness. There isn't a pill for that, unfortunately. Right. What you can do is give people a sheet of paper with 2 columns and say, on this side, I want you to write the strengths that you've used in the past to overcome big problems in your life. And in this column, I want you to write the top 10 things that are bothering you now, and then see if you can draw some connecting dots between them.
Yeah.
Sometimes just giving it a name of demoralization makes people say, yeah, that's exactly how I feel. I thought I was depressed, but I'm not. And maybe I should be out exercising more.
Right.
And maybe I should try to make a little bit more effort with my family.
Well, I think that your openness is a really great tool to educate people about what people go through. I think, especially when I know you've talked about how some of the things you learned from other patients, not from your doctor. And it is a good reminder of how important connection is, and I think the importance of talking about these things, because if you don't ask, you're not going to find out that how someone's coping, or if they're depressed, or if they're feeling demoralized. So I thank you for what you do in terms of taking what you've already experienced throughout your career as an oncologist and palliative care doctor, and now sharing that as a patient as well.
Well, thank you. One of my favorite authors, Walker Percy, who was a physician who never practiced, wrote a wonderful book in 1967 called Love in the Ruins, or The Adventures of a Bad Catholic at a Time Very Near the End of the World. But the protagonist is a physician named Thomas More, and he's admitted to what he calls the insane asylum himself for depression and mood swings. And he writes, doctors, if you listen very carefully to your patients, they will tell you not only what's wrong with them, but what's wrong with you. And it's so true.
Wow. Well, thank you so much for being with us here today, and for all of that you have done to be deserving of this Ellen Stovall Award. We're so grateful that you are here with us today, and for all that you've done. Thank you.
Oh, thank you.